another of our series this week on decolonising DMU. Just to remind everyone that we have a no space for hate policy here at DMU, and just to anybody wants to know any more, there's a email address there. Does anybody want to say if it's too dark? We have the lights off in the room. We're in a hybrid space here. Is it too dark? People perhaps put something in the chat room or come on the call.
Yes, it is, Bernie. It's too dark.
Too dark. 1 minute then. Thank you.
Don't worry about us.
Now too bright. Who knows? Can everybody see the slides though?
Yeah, they're on.
Fantastic. Right. We're now starting to record. So welcome.
Hi, good morning. It still is morning. Welcome to Decolonising Midwifery Education. Who are we? Well, there were 6 of us that actually got together as a writing group. All 6 of us aren't here today, but here today are Zahira Esat, my colleague, Bernie, Bernadette, Gregory, and myself, Diane Menage. So what did we do? So I want to talk to you about 2 papers that we wrote and what led up to it. First of all, perhaps it's best to tell the story of why we did it. So this was something that happened when Black Lives Matter was very much in the news, and we were looking at what we could do as a midwifery team to look around at how we teach student midwives and how we can improve that. It's one of those things that I can't tell you the exact time that we began to see all the problems. It wasn't a particular day, but suddenly it's like one of those things that, you know, you start to think about something and there it is. It's there again and again. Myself and my colleague Rachel, we were actually, I think, doing some assessments for the neonatal examination of the newborn exams. And we were examining students on their assessment of the neonate, and we realised that there was a real lack of knowledge about how to assess new babies of different skin tones. So a lot of the language, we just started to notice we were listening to language about the babies pinking up, the baby should be pink, and we realised that we needed to do some work in this area, and we had a bit of a discussion after that. And long story short, that really led to us getting together, a group of 6 of us in the midwifery team who were really interested in this and looking at how we could create some sort of resources. The thing was, there weren't any resources out there. There was nothing in midwifery whatsoever about this. And so we needed to be quite courageous and say, well, we've got expertise within the team. We're going to take that first step. Initially, we thought that we would write the paper about neonatal assessment, but very quickly we thought, well, this needs to be also about maternal assessment. So it's 2 linked papers that we wrote. We wanted to write them for a journal that lots of midwives take, lots of ordinary practicing midwives take and read, rather than just for academics. So we submitted them to the practicing midwife. In fact, we wrote to them and said, would they be interested? And they nearly, you know, snapped our hands off. And there were 6 of us, and we wrote paper 1 and paper 2. Paper 1 was the maternal paper. Paper 2 was the neonatal paper. And they went into print in the journal in September last year. But they took the unusual step of making them open access. We didn't have to pay for that privilege, they just made them open access because they thought they were such important papers. So So here's the links to the papers. So this has been recorded and you'll have this as a resource, so you don't need to write any of this down. There are links there to both papers and they are open access. So part one is about assessing women with darker skin tones in midwifery practice. Part two is neonatal assessment.
Okay, so the first paper focuses on assessing maternal well-being in women with darker skin tones. So you'll notice from the title that we were interested in ways to decolonise midwifery education. So what did we actually mean by that? So decolonisation meant lots of different things to all of us, but it was about recognising as midwives that the care and support we provide and the system in which we work does not always meet the needs of all women, birthing people and their families. And we know that health disparities exist, and so decolonising is part of that process to ensure equity is achieved for all. So we wanted to contribute to achieving this by looking at ways to decolonise teaching and to ensure the education of our student midwives help to dismantle racism in clinical practice. And why is this necessary? Well, we know that inequity and racism contributes to the disproportionate number of maternal deaths in the UK of Black, Asian and other minoritised groups. So if we look at maternal mortality rates, it is possible that often there is a lack of understanding and confidence in recognising complications in women with darker skin tones, and so signs of morbidity in women is often missed. So we really hope the papers will contribute to addressing the disparity amongst women and babies and build that confidence in skin assessment when caring for them. And again, why is this necessary? Well, in midwifery practice, skin assessment is a really important part of any physical examination of women and babies. And we often depend on visual cues that tell us about the woman, but these visual cues are often less apparent in women of darker skin tones. And we know there's very little literature, including images, on how conditions may present on darker skin tones, which, as you can imagine, is really problematic because we use skin assessment, for example, when taking a blood pressure or taking the mother's pulse rate, and we use these cues to ensure well-being, so we can assess well-being, and also to make sure if there are any suspected complications, they're picked up early and referred to prevent a poor outcome. But we also have to ensure that we address the Eurocentric language that we use. So often you'll notice women's skin being described as being pink or red or pale, which is absolutely fine if it's a woman of a lighter skin tone. But then how do we describe or what do we look for in darker skin tones? And so now what I'll do is I'll share some examples of how we use visual cues when identifying any skin changes in women of darker skin tones. So if we explore the subtleties involved when assessing the skin of women with darker skin tones. So I mentioned how midwives often use visual cues, and they often use these visual cues to assess a woman's progress in labour. So if we consider, for example, the purple line. So for those of you who are not aware of the purple line, it is a line of temporary skin discoloration that can be seen in the anal cleft of some women as they progress in labour. And so it gets longer as labour progresses, and some midwives may use it as an indicator of how the labour is progressing, and it's less invasive, as you can imagine, in comparison to, say, a vaginal examination. Now, the purple line is much easier to visualise in women of a lighter skin tone, and it's often described as being red or purple, but actually it may even be brown depending on the woman's skin colour. So if we think about the birth environment, as midwives will find ways to optimise the environment to aid with that facilitation of physiological birth. So the lights are dimmed, which means then the purple line may not be seen. But also women may not be in a position where we can see it. So they might not be in an all fours and upright position, so we can't see the purple line very clearly. But also in women of darker skin tones, the purple line will be less visible, which means in such cases it is a less useful visual cue. So then what do we do in those situations? We consider the rhombus of Michaelis, which you can see on the slide, which is a more helpful sign. And as you can see in the image, it appears like a lump, and it's a kite-shaped area between the sacrum, which is just above your tailbone, and the ilia, which is the sides of the pelvis. And this area pushes backwards, and essentially what is happening is it increases the size of the pelvis, which is really important in aiding physiological birth. And it's really noticeable towards the commencement of the second stage of labour, when women will then soon birth their baby. And so it's when the head, the fetal head, descends deep into the pelvis. And midwives will report that they have seen it, but also felt it too. So if we consider things like breast conditions, which is often described as being pink or red in situations where, as you can see in the image, the mother has cracked nipples or mastitis, but actually in women of darker skin tones, these colour representations will not be seen. And again, if we consider other examples, so deep vein thrombosis, which is a blood clot in the vein, usually the leg. So you can see in the image, it suggests there's redness to the affected area, but not all typical signs like redness will be seen in darker skin tones. So what do we do in those situations? So what we encourage is to look out for changes in skin colour, like hyperpigmentation. So where the skin becomes darker in comparison, so darker in colour in comparison to the non-affected area of the skin. So what we recommend is that you use visual and tactile cues like touch to establish if there are any changes in the skin's appearance. And it's also important to listen to the woman, listen to her concerns, take note, and also ask questions of any related signs and symptoms. And so now what Diane will do is explore the second paper, which considers how we assess neonates of darker skin tones.
So in the neonatal paper, again, we wanted to make the point about skin assessment being absolutely fundamental, but that historically the teaching of this has been all related to neonates with lighter skin tones. So we wanted to look at how we can make the teaching and learning and the assessment actually fit for purpose. So I'm going to give just some examples from the paper, which would be our cyanosis, dermal melanocytosis, and neonatal jaundice. So look at cyanosis first. So really important that midwives are taught how to assess a baby for cyanosis, for that blue discoloration, which could indicate cardiac or respiratory insufficiency. It could indicate some sort of congenital abnormality, all sorts of things. So very important. We do this right from birth. You may or may not have heard of something called the APGAR score. This was a kind of numerical score for the neonate at birth, 1 minute, 5 minutes and 10 minutes, where 5 areas are assessed. And in each of the 5 areas, the baby gets kind of a point system, 0, 1 or 2. Now, one of those areas that we assess is colour. Now, to get to the maximum score for colour, the baby, according to the APGAR score, needs to be pink all over. So already we've got a problem there. It's the APGAR score is very useful for certain things. It was invented in the 50s by Virginia APGAR. That's where it gets its name from, and it's never really been updated. But we suggest in the paper that that part of the APGAR score is not really fit for purpose. So we're being quite courageous there in sort of starting that debate. If we look at how we teach and assess student midwives in identifying cyanosis, and we're talking about central cyanosis for the neonate, peripheral cyanosis, blue extremities, very common in the newborn for the first 24 hours. So we're not so much concerned with that initially. We want to teach how to assess the neonate for central cyanosis, which could be a very grave sign of cardiorespiratory problems. So we noticed this when we were assessing student midwives, that they were often talking about the importance of the baby pinking up, and that's how they would assess, make sure the baby looked pink. So sometimes in assessments, maybe in scenario settings, when we did maybe scenario-based learning, we would perhaps ask about, well, how would you assess for central cyanosis in the neonate with Black African parents? And we noticed that this was often really throwing the students, even though in practice they are caring for mothers and neonates of varying, skin colours. We've got a very diverse population that use maternity services in this area. So it's not as if they're not seeing it, which in some parts of the country might be the case, but not here. So we wanted to write about how it's important to differentiate between central cyanosis and how you recognise it in babies with dark skin colours. So we talk about how you do look at the skin, but the skin is not your primary thing. In actual fact, the lips, the mucous membranes, the gums, the tongue are where the tissues are very thin, and they will be the same. They will be consistent in babies of all skin colours. So we encourage them to assess this for cyanosis. I'll go on to dermal melanocytosis now. So this is often, historically, this has often been called Mongolian blue spot, or sometimes slate grey nevus. The proper name is dermal melanocytosis. So we talked about this because it's very common in Black and Asian neonates. So about 90% of Black and Asian neonates, according to some sources, will have these skin marks. What's in a name? Well, we do talk about this in the paper, and we question and we strongly recommend that the term Mongolian blue spot is now not used because it's not accurate. It's not got any scientific backing. There is no scientific backing for a Mongolian race. So we will strongly recommend that this is called dermal melanocytosis or simply blue spot. So talking about the name initially, and then talking about some of the implications of this. So one thing is that it can often be confused with bruising on a baby. So, and there are recorded cases of families being referred to social services, child protection issues, wrongly accused of perhaps harming their babies, and it's turned out to be dermal melanocytosis. Now, obviously, we've always got to be aware of looking out for safeguarding issues, but what we want to do is we want to teach midwives to be confident to be able to distinguish between a bruise and dermal melanocytosis. So we talk about that in the paper and how the difference between those two things, and how in babies with dark skins, it may not be a blue colour, it may just be a darker colour, and that you can distinguish this between a bruise because it's going to have more uniform edges. It's not going to change. It's not going to be associated with any local inflammation or any local discomfort. And the importance of actually documenting any skin lesion, whatever it is, on a body chart for recording and monitoring. And then neonatal jaundice, very common. Up to 60% of all babies will have some sort of physiological jaundice in the first week of life. And we talk about this to student midwives all the time, and they learn this in practice. They see midwives assessing babies for jaundice. But if we think about babies with darker skin tones, then we need to be looking much more at the whites of the eyes, the sclera, the gums. The palms of the hands and the soles of the feet are areas of depleted pigmentation, so they will be good areas to assess on babies with dark skin tones. Also blanching the skin, digital pressure, to have a look at the any signs of yellow pigments that way. So that's it in a very brief nutshell, just 3 examples.
Okay, so we do recognise that our students' learning also takes place in the practice setting. And so there are a number of aspects related to individualised care that we do encourage them to consider. So we explore topics which make them feel uncomfortable at times, but important, like I mentioned, conscious and conscious racial bias. to ensure that they avoid making assumptions about women and their families, and also so that they address any stereotypes, including negative stereotypes and attitudes and assumptions that they hold as well. And that's because it's really important that we are able to make a full and thorough assessment of women, which includes listening to them, taking a detailed history, and also making sure that we communicate effectively. So we encourage our students to consider how effective the communication is in situations where, for example, there is a language need, and we explore how they address this. And students often have a lot of curiosity around cultural birth practices and rituals, and we encourage them to respectfully and sensitively ask women about these. And these conversations are incredibly important because they are effective in helping them to understand how groups are often homogenized and the problem with doing this and the effect of doing this. And we also encourage students to understand the women, learn about their expectations and experiences, and consider how we provide care, which then all contributes to them understanding if the care and support and services we provide truly meet the needs of all women.
So what's been the impact? It's been really very good, very surprisingly good. So we've had local impact while we're here today doing this, but there's also a podcast on the DMU Decolonising website. We have been having interest from Leicestershire Live, and they ran a piece on it, and I forgot something about Leicestershire Live. Yes, the piece was called "Teaching Needs to be Colour Aware and Not Colour Blind," and that's become a bit of a excuse me, a bit of a sort of strap line for us, and people are recognising that we said that in paper one, and people are kind of using this and discussing it and debating it. It doesn't come any higher than the International Confederation of Midwives president, Frankie Caddy, who tweeted this on Twitter. Thank you, DMU Leicester, for publishing the report into Decolonising Teaching for Midwives. So that was absolutely fantastic to see. And we're getting feedback all the time from far and wide. Zahira's had emails from high-profile midwifery academics in Australia, and I've just heard in the last this month about the cross-professional use of this. So Warwick Medical School have given me some feedback about how they have now added it to their resources with medical students. So absolutely fantastic to know that we've started the ball rolling, and we were courageous to do that. We wondered if we should do it, but we did it, and it's got a fantastic reception, and it's being spread far and near.
So reviewing our curriculum, we are going through a revalidation process at the moment, and a prototype online space was created by Dr. Rob Wheel from Celt here at DMU, and it's a hub through which we can use scenario-based materials, and they're being developed as co-creation events with our students, staff, and our researchers in the Centre for Reproductive Research, and my nursing colleagues who are on the call today. And it's the idea to co-create then that we're developing and engaging the teaching and learning and changing the teaching and learning strategies, that a lot more will be online in our new curriculum. So it comprises at the moment of an interactive map, part of a fictitious town called Montfort. I was awarded a Kite Fellowship in 2020, so I was given some time to develop some more of the scenarios, and you access it via the map. So co-created fictionalised stories are used to build characters and scenarios. Students can reflect then upon the lived experience of service users in their care. They use their own in-practice experience. They adopt a solutions-based approach to those care issues, and then they can be signposted to further independent study resources as either preparatory or adjunct material. And that's part of our universal design for learning here at DMU, UDL for short. Lecturers can then adapt those characters, evolve those stories over time, discuss encounters with health professionals during their reproductive journey, prenatal to postnatal care, and then we're aiming to incorporate more and more of our student and staff voices in that co-creation of materials. And then I feel that that authenticates our teaching materials and reflects again our multicultural and diverse community, as Diane mentioned here in Leicestershire. In the project that preceded the Decolonising DMU project, Freedom to Achieve, the work that we did, we're working with individual programmes in developing curricula, said that to see themselves, the students evaluated that really strongly, but in evaluations. But mindful of that feedback that we heard, and I was quite shocked sometimes that when they were multicultural, multi-diverse resourcing materials, it was always with a negative lens. Things like knife crime being discussed, or problematic families, or drug abuse, or inappropriate use of NHS social care services. So we've been mindful of that when we've been creating our new materials. And I think, as Diane said, we've started the ball rolling, but other people are doing great work. I think it's important to talk about today. So Malone McWendy is a third-year medical student based in London at St George's Kingston University, and he was appalled at the lack of imagery that was available representing different ethnicities in his medical textbooks. He states that only 4% of images in any dermatology textbook show conditions on skin of colour. So he is now on a global mission to create the world's largest database of imagery on black and brown skin. If you're interested, there's his website. You can contact them and upload pictures of yourself, your own skin colour, conditions, and then he's generating that international database. Illustration by a medical student last year went viral, and the feedback was that for many people they had never seen an image of a black fetus represented in a medical textbook. This is his link to his TED talk, where he now describes himself as the black fetus guy. He's had such global attention that that's now his actual tag. He talks about how, you know, he can't understand how that's not happened in the past. Why has there been that dearth of literature? And some of our students are checking on our reading lists now and saying, yeah, where are the images? And if they are, they're of, again, developing countries and poverty. And that's the only representation of people of colour or women of colour. At a presentation a few weeks ago, one of the students had actually done an actual review of all of our core textbooks, which again, we've talked as a team in Decolonising DMU work that we perpetuate those things by looking at the same resources and just recommending the same books year on year. And my colleagues here are working in the library, and you'll see some of the DMU events this week where we've been talking about that very issue. Other things that people say may be missing in our curriculum: sickle cell disease. This is a report that I've linked to you here, No One's Listening. It was triggered by a coroner's report into the death of Eva Nathan Smith in the North Middlesex Hospital last year, that shocked the nation. And the mistakes made in his treatment led to this report, which is an all-parliamentary review. And the coroner did feel that those mistakes had led to his early and avoidable death. And it brought into sharp focus that lack of understanding of issues such as sickle cell, the battles patients have to go through to get proper treatment, and the terrible consequences which then can come about as a result. And is it because sickle cell is a condition that predominantly affects people of African and Caribbean heritage? I mean, people of every race have a right to equality in health treatment. The experience of people living with sickle cell is that they feel the failings in treatment, that lack of understanding, and maybe insufficient training of health professionals going forward. And that's outlined in this report. It shows people are, regularly treated with disrespect, not believed or listened to, and not treated as a priority by healthcare professionals, which suggests a very deep inequality and overt racism which in the healthcare system, which people in the NHS are trying to address. And if it is this serious and long-standing issue, it has to be addressed. We're in 2022. So what do we still need to do better?
Okay, so as a team, we know that there are a number of things that we do need to consider. So the list is not exhaustive, but there are some aspects that we feel we do need to consider, more imminently, and I'm sure we can keep adding to that list And hopefully the list will help you consider ways to decolonise your practice too. So think about, exploring our reading list, our resources, and our imagery. So as we've already mentioned, when we were writing the papers, it became quite clear very quickly that there's so little literature written on skin assessment of women of darker skin tones, including the images, very few images on how conditions present in darker skin tones. And this ties into how we make teaching meaningful then. So, we need to share images that share a message rather than a tokenistic gesture. And Diane touched on the language that we use. So recently our local trust removed the term Mongolian blue spot from their paperwork. And students have also questioned why this term is still being used in the literature. So we do need to point things out when they are wrong. And as I've mentioned a few times now, those painful, uncomfortable conversations like addressing things like conscious racial bias. And these conversations are vital in our pursuit to ensure equity for all women and families. So if we consider our teaching, including resources, think about how they support the learning of our students and how they prepare them to care for the diverse population in Leicester. And also, how do we engage and involve our students? So there's various things that we've tried to do. Bernie has provided examples of her co-creation work with students and how they have fed into the Northside project, but also asking students to do simple things like, reviewing scenarios which may hold unconscious bias which we're not aware of, or even encouraging them to create their own scenarios which has that inclusivity. And we recognise, as I've said before, that our students do learn in practice, so we do need to find ways to collaborate with practice as well, to engage with our midwifery colleagues in the practice setting.
So, I'm going to say something which I should have said at the beginning, but we had a bit of a false start, so I forgot to say it. And that is that throughout this presentation, we've used the word woman. And we do that because for ease of presentation, and also because the vast majority of the adults that we look after do identify as women, but we do so in the spirit of inclusivity and absolutely acknowledge that not all birthing people do identify as women. So having said that, now just remains for me to say that here are the papers and links to them if you are interested, and we would encourage you to go there because they're open access. Recommended further reading also. So with that, I'd like to throw it open to any questions. Thank you for listening. Thank you, audience.
I was just going to ask, so I did pick up on the word woman, and I'm glad you said that.
That was the start, which, because we had a funny start. That should have been the start.
But I just wondered whether there's a reluctance to use a word like mother, for example, which would portray the same thing, but would take away the genderised aspect of that.
So we often say women and birthing people. Sometimes we say mother if we're talking about the dyad, the woman, the mother baby dyad. I think it's about a question of how would most people that we look after identify themselves, and that is as a woman. So we definitely don't shy away from saying woman, but we often say women and birthing people, and we do talk. I would normally start by saying this is absolutely inclusive. It's all birthing people.
There was an excellent report just recently published. I'll put that in as a link, talking for the first time the largest report outside of the US of people who have experienced maternity services in the NHS and have been have quite a lot to say about the inclusive language when they don't automatically like the term woman, and when they're being questioned about various things that are seen as only affecting women. So I'll put that link to you. It's a very interesting report.
Have we got any questions on the?
I'm keeping an eye on the chat. There's nothing. There have been a few comments on the chat.
Oh, good.
Well done, midwifery team. Brilliant work. So Diane says this has been true for a while, teaching safeguarding. So this was about kind of the images and diverse images. I was asked to share images of injuries, scabies, rashes on different skin shades to social work students, and I really struggled to find any.
Can everybody, I don't know if everybody can hear what you're saying from there, but
So Mel's just read out one of the comments about True for a While, that teaching safeguarding, asked to share images of injuries, scabies, rashes on different skin shades to social work students and really struggled to find any. Excuse me. So I think that is what we're talking about, that database. We need to be asking people to share imagery. I mean, certainly with the project work, we get caught up on things like copyright, and we're so worried about putting imagery, so then we don't put imagery. But we could collate a lot more imagery than we do, and look wider across global imagery as well, rather if it's not there in the UK. Good question though.
Bernie, you might need to just repeat. Would it be possible for you to share the link to the podcast? I've been looking so that I could share it in the chat, and I couldn't find it on the Decol website. So for anyone who's attending, if they want a link to the podcast at some point, obviously not now. And then we can
So Mel's made the point, we're struggling to find the link to the podcast made by my midwifery colleagues, Maureen Rayner and Dr. Zahira Assat. So we'll try and put the link in there in the chat. Or any other questions? Thank you for the kind comments. Question from Leslie.
Not a question really. I just really wanted to commend you, Penny, and the team for the amazing work. I mean, it's clear to see how it's not just relevant for midwifery, but across the board, thinking about healthcare as a whole. So just a thumbs up for me, and well done, I suppose. This is a really great piece of work, and it's clear to see how it's contributed significantly to those conversations that we should be having. And you can see why there are those disparities in outcome, in maternal outcomes, if you look at the education aspect of midwives and how they're not taught to assess different skin colors and so forth. So yeah, just a well done from me. I don't really have a question.
No, thank you for that, Blessing. So Blessing said, it can see that how it could lead to poor outcomes. So Diane mentioned from a neonatal perspective about things like social care, social, child protection, social work involvement. Zahira mentioned about maternal mortality and morbidity, breastfeeding support. So yeah, we can see clear reasons why this is so important to elaborate on within the curriculum. And as I say, sickle cell, things like that. How much time are we spending on the curriculum talking about issues that are such as female genital mutilation, circumcision, and other things that reflect the wider multicultural global healthcare issues for the women. So
we were discussing just before the presentation about how when we were looking for literature, we were really struggling, and we looked very widely. And I came across a paper, and it was about women in America, how Black women, when they experience sexual abuse, a lot of the cases don't go to court, and that's because the initial examination isn't carried out with good lighting and so on, and that really upset me to hear that, because often you wonder why it is that these cases don't go to court. But when I read about this, it just made me feel quite upset, and relating it to then midwifery practice as well, in terms of how many things are missed.
So that links nicely to one of the questions and comments. One of the reasons we're running these events this week is to celebrate what we've been doing at De Montfort University, but it's also to talk about and give ideas to other teams how to start this conversation. Nursing, for instance, one of my nursing colleagues has made that comment that, yes, of course, it's for pressure area care, it's for within the nursing curriculum, it's relatable. And then Blessing in her programmes, of course, the health care sector too. And then, as Diane said, within medical education curricula too. So yeah, we hope people have taken something away and could relate it to their own field of practice. with their own examples. Any other questions?
Just posted one in the chat so that everyone can see.
So Melanie?
Yeah, Mel.
Mel? So you tell us that you're from a law background, so to forgive your ignorance of the medical side of things, you don't need any forgiveness. So how far do some of these issues impact on the much higher mortality rates of Black women in childbirth? Absolutely it does. And we have the MBRRACE report, which tells us about maternal mortality. And consistently what it's showing is that the rates are not really significantly reducing. And it's really disturbing to learn that actually these are rates in the UK. And it's not related to women who are migrants. So often we associate rates, poor outcomes to women who migrate to the UK, but it's not. It's women who speak English, who have lived in the UK since birth. And their families tell us stories about not being heard. And that's really disturbing, that really upsets us. Unfortunately, the report just tells us the figures. It doesn't really give us much context about each woman, and that's something we do need to consider. So certainly it does contribute to maternal mortality rate.
Yeah, and I was just going to say, absolutely, we need more research, because we can't actually quantify that. We actually haven't got the research behind it. But what we can do is to encourage more research in that area, maybe even be involved in it, and also make sure that everything that we're doing is trying to minimise that.
And there is a project currently taking place, and Natalie Dark, forgive me Natalie if you're listening and I've not got your surname right. So she is looking at women's experiences during COVID. So it's not just Black and Asian women, any women that identifies as being of a minoritized group. So that would be really interesting to hear of their stories, but also we are listening to the voices of midwives as well. Very little literature around this. So Isabel Bowler's work was in the 90s, looking at how midwives see South Asian women, and the findings from that study was really disturbing, how they see women. But since then, there hasn't really been much work. So certainly that research is really important. But we know of lots and lots of anecdotal evidence.
One way of trying to address that is we've been trying to actively recruit students from a wider multicultural background. We're working locally, nationally on that agenda, Royal College of Midwives, the National Nursing and Midwifery Council down, perhaps that's one of the issues, but then also working with the fact that the data also from a law background is, why are there not more staff at the senior echelons of the NHS and in positions of power? So we're actively recruiting. We have a value-based recruitment process here at DMU, and we have increased the numbers of students from different ethnic minoritized groups, and they have a lot to say. But again, one of the things we found with the Freedom to Achieve and Decol project going forward is, the way we teach and the way we allocate personal tutor groups and clinical groups, teaching groups, do people actually hear the voice of those students, and where are they represented, as I say, within the curriculum, but to have that voice to say, this needs to change, we're not happy with what we've heard, what are you doing about it? So again, we've got colleagues across DMU that have they've instigated the similar to the NHS Speak Up Guardians, where we've encouraged and helped recruit students who feel that they can go to various meetings and put the case that this is not representative, or we're not happy with what we've seen out in placements. Again, some other events this week talking about some of those issues. Do please feel free to contact DMU events at dmu.ac.uk if you want to join any of the other events this week. Any other questions though, or any comments?
Comments in the chat there.
So I think it's Diane who's responded to Mel's question.
Lisa's made a suggestion.
Yeah, so Lisa, hello Lisa. We don't have, is there somewhere at DMU that we could start a visual resource board or something like that for images of things like blue spot and central cyanosis on a range of skin colours? It's a great question, as I expect, Lisa, one of our third year midwifery students who's just won an ILANTHE Midwifery Award. It would be useful to not only for midwifery but also nursing. So I suggest perhaps a database rather than a board, but yeah, we need a sort of repository. It's an excellent idea, something a lot of my colleagues from the school learning and teaching group are on here today that may be able to start that process. Because yeah, the point I made earlier, it's about copyright. So there are some copyright free imagery that we've used, particularly within things like Northside, but it's a very important point, copyright. But if it's only individual photos, I don't feel who've given permission, I don't think that's the same issue as copyright looking through data, journals and using other people's imagery. But great question. Yeah, so the PDF, the Mind the Gap, is what Malone Mukwende's work is, a Mind the Gap resource, excellent piece of resources. Where he started that whole process about imagery within textbooks and within the medical curriculum.
I think Donna's asking for the PDF. We can.
Oh, you want the PDF? Yeah, well, I can do that. Any other questions, comments? Oh no, I was going to say, she says she has it. Yeah.
Oh, she has it.
She has it, so she's saying it's a good resource. I agree with you, Donna, it's a very good resource. Okay, well, perhaps stop recording.